Precocious puberty is the early onset of puberty, defined as the occurrence of puberty less than 8 years in girls and less than 9 years in boys. It could be divided into gonadotropin dependent, which is central or true precocious puberty and is characterized by the early breast development in girls or testicular development in boys. The second category is gonadotropin independent puberty that occurs due to abnormal peripheral sex hormone secretion, resulting in isolated development of certain secondary sexual characteristics. This may involve autonomous testosterone production in a boy or autonomous estrogen production in a girl. In addition, testosterone production from the adrenal or the ovarian tumor can induce virilization in a girl. So assessment of precocious puberty, age of onset when secondary sexual characteristics was noted should be inquired. What features was present and in what order did they appear? Like virilization, any history of virilization, genital or breast enlargement, galactorrhea, which is very rare, menarche or cyclical mood changes. Is there any evidence of recent growth acceleration? Is there any family history of early puberty, any past history of adoption or early weight gain, or prior CNS abnormality or insult, radiation? So to summarize, the age of onset, the features which was first noted, any problem with the growth as well, any family history, and the past history. And the examination should include breast and genital and testicular size, the degree of virilization and extent of virilization. Splenomegaly in girls indicates abnormal androgen levels. Neurological examination should be done, particularly visual field assessment and fundoscopy. Abdominal or testicular masses should be determined to rule out any tumor in the skin. We should see for the capillary spots, which are present in Matune-Albright syndrome, and assess the height and height velocity over 4 to 6 months. Biochemical investigation should include the following investigations clinically indicated: breast radiograph for the bone age, because precocious puberty may lead to early fusion of the epiphysis. So we should check the breast radiograph, thyroid function test, because thyrotoxicosis may lead to early fusion and precocious puberty. Sex hormone levels, like including the testosterone, androstenedione, DHEA sulfate, estrogen, LH and FSH level, baseline at 30 and 60 minutes post-IV LRH, 17 alpha-hydroxyprogesterone levels, baseline at 60 and 30 minutes post-IV sanithin if congenital adrenal hyperplasia is suspected. Tumor markers including alpha-fetoprotein and beta-HCG, 24-hour urinary steroid profile if there is suspicion of any enzyme defect in the steroid biosynthesis, abdominal ultrasound to see any pathology in the adrenal glands and ovaries, MRI scan to see any tumor or any other pathology in the cranial and adrenal glands. For those with hypogonadotrophic hypogonadism, mutation screening for the monogenic causes should be done. These genes include KL1, FGFR1, GnRH, HR, KIS1 receptor may be indicated. So for the quick revision, it is KAL1, FGFR1, GnRHR, and KIS1. Central precocious puberty. This is due to premature activation of the pulsatile LHRH secretion from the hypothalamus, and the normal progression in the physical changes is maintained, that is consonant. As precocious puberty is defined as occurring younger than 2 standard deviation below the average age, in a normal distribution, 2.5% of the children will have early onset puberty. In practice, in girls, central precocious is more likely to be idiopathic or familial, whereas boys have a greater risk of intracranial or other pathology. The causes include idiopathic or familial, intracranial tumors, hydrocephalus, and other lesions, postcranial radiation or trauma, intracranial tumors, in particular the optic nerve glioma and hypothalamic germinoma, hematomas, hydrocephalus, and non-specific brain injury with cerebral palsy. It may also be triggered by long-standing elevation in the sex hormones resulting from any peripheral source or adrenal enzyme defects that is late presenting symptomatizing CH or inadequately treated CH. Hypothyroidism with elevated TRH stimulates FSH release, which is a rare phenomenon, gonadotropin releasing tumors, that is pituitary adenoma or hepatoblastoma. Treatment includes, aim of the treatment are to avoid psychological problems for the child or the family and to prevent the reduced final height due to premature bone maturation and early epiphyseal fusion. A final height protection is often necessary when considering the need for the inhibition of puberty. Significant sparing of the adult height is only likely to be achieved if presentation occurs and the treatment is started in less than 6 years of age. Pituitary LH and FSH secretion can be inhibited by the use of LH-RH analogs, which include goserelin 3.6 mg subcutaneously monthly or 10.8 mg subcutaneously 3 monthly or triptorelin 3.75 mg subcutaneous or DPIM every 2 weeks for the first 3 injections, then 3 to 4 weekly thereafter. Treatment efficacy should be monitored regularly by the clinical observation and ensuring that LH and FSH level post-IV LRH remain at low prepubertal levels. The dosing intervals may need to be reduced if there is evidence of inadequate suppression of pubertal development. So the monitoring is done clinically and as well as biochemically, keeping the LH and FSH level at a low prepubertal levels. In gonadotropin-independent precocious puberty, at least 2 genetic syndromes have been identified, both resulting in abnormal activation of the gonadotropin receptors, independent of the normal ligand binding. Thus, in these conditions, the gonads autonomously secrete sex hormones and the level of LH and FSH are suppressed by the feedback inhibition. The first is Matune Albright syndrome. This is a sporadic condition due to somatic activating mutation of the GS alpha protein subunit, which affects the bone, leading to polystotic fibrous dysplasia, skin leading to Kaplan spots, and potentially multiple endocrinopathies. A number of different hormonal receptors share the same G protein couple, cyclic AMP, second messenger system, and hyperthyroidism or hyperparathyroidism may also be present as these hormones are dependent on the G protein coupled activation. All cells descended from the mutated embryonic cell line are affected, while cells descended from the non-mutated cells develop into normal tissues. Thus, the phenotype is highly variable in physical distribution and severity. Testoxicosis. This is a rare familial condition resulting in precocious puberty only in boys due to activating LH receptor mutation. So the LH receptor would be constitutionally activated. Testes show only little increase in size, and on biopsy, lead axil hyperplasia is characteristics. Treatment is by the use of androgen receptor blocking agents like the cyproterran acetate and aromatase inhibitors. Peripheral sex hormone secretion. Excessive peripheral androgen secretion may occur due to CH or androgen secreting adrenal or gonadal tumors. These children usually have rapid growth, advanced bone age, and moderate to severe virilization in the absence of testicular or breast development. Peripheral estrogen production from the ovarian tumors is a rare cause of precocious breast development in girls. Premature thelarchy. Premature breast development in the absence of other signs of puberty may present at any stage from the infancy. Breast size may fluctuate and is often asymmetrical. The cause is unknown, although typically FSH levels are elevated, while the LH is not mostly normal. An ovarian ultrasound may reveal a single large cyst. Bone maturation, growth rate, and final height are unaffected. So in premature thelarchy, there would be breast enlargement, FSH would be high, ultrasound ovary would show a single large cyst. Rest of the things would be normal. Thelarchy variant. This is intermediate condition between the premature thelarchy and central precocious puberty. The etiology is unknown. These girls demonstrate increased height velocity and the rate of bone maturation. An ultrasound of the ovary reveals a more multicystic evidence as seen in true puberty. There is probably a whole spectrum of presentation between premature thelarchy and true precocious puberty. Decision to treat take into account height velocity and final height prediction. Premature adrenarche and pubarche. The normal onset of adrenal androgen secretion, that is adrenarche, occurs 1 to 2 years before the onset of puberty. Premature or exaggerated adrenarche is thought to be due to increased androgen production or sensitivity and presents with mild features of virilization, such as the onset of pubic hair or acne in the absence of other features of puberty. Clitomery in girls suggest a more severe pathology with excessive androgen production, which may occur in CAH or androgen secreting tumor. The diagnosis made in the presence of pubic hair and axillary hair, the absence of the breast or testicular development in children aged less than 8 years, and it is more common in girls. The management of premature adrenarche usually only requires reassurance after the exclusion of other causes, as there is no significant impact on the final height and the onset or progression of puberty. Some of these girls may subsequently develop the features of polycystic ovarian disease, and in these cases, treatment should be directed at the presenting features.